All right. Module F-5, airway clearance. Basically, what we're talking about here is going to be the suctioning of the airways, brief review of the upper airway, and then talk about pharyngeal suctioning, talk about tracheal suctioning, and we'll talk about specimen collection. So by the end of this module, we'll talk about the process for determining proper catheter size, as well as other equipment that is involved in suctioning. We'll also list the main differences in suction technique between infant, child, and adult. And we'll look at given a mannequin or some sort of a device will demonstrate the proper suctioning of the upper airway and also collecting a specimen. Maybe we need a little video to start us off here. Maybe not. Okay, well, we'll skip that one for now. Let's go back and review some of the upper airway as far as its anatomy and its function. First of all, the upper airway, again, has multiple functions. We know this. It filters, warms, humidifies, inspired gas. It's airway protection in the form of the glottic opening, closing, the form of cough to remove anything that might have, or prevent anything that, getting down the tracheobronchial tree. It's also involved with speech and smell and taste. And obviously, it's a conduit to the digestive tract. Three paired, three unpaired cartilages that we have that function the larynx itself. And this is the universal algorithm that is out of Egan that talks about management of the airway, specifically in a patient who has either in cardiac arrest or is in respiratory arrest, how we would manage it. There is a clinical practice guideline for nasopharyngeal suctioning, and basically it's the need to maintain a patent airway, remove secretions from the trachea when a patient who has not able to clear secretions, or that despite their best effort, they're still not being able to mobilize. We can talk about suctioning of the oral cavity. It's not going to be an optimal route for reaching down into the trachea. Nasotracheal suctioning, where we're going through the nasopharynx and then into the hypopharynx. There is the possibility of being able to access into the trachea. It's not a guarantee. If you truly want to be able to suction out the trachea and the airways further down, you need to have an artificial airway placed. One of the things we always should do is do some sort of assessment, whether there's a need for suctioning. There's not an indication for suctioning, then the patient should not be suctioned. Some findings we may have are coarse crackles, or what we used to call rhonchi, either audibly from the door or using a stethoscope. You can also have rhonchial or bronchial fremitus, where we actually feel on the chest wall vibrations that are basically secretions in the larger airways. Sometimes you can see the secretions in the airway itself, and the presence of a weak or ineffective cough. And obviously these patients would be tachycardic, tachypnic, exhibiting a significant work of breathing and inability to adequately oxygenate. Some of the equipment we need a vacuum source that has an adjustable pressure regulator. We'll need a collection container and tubing. We'll need a sterile suction kit, which has a catheter of appropriate diameter, some disposable gloves that are sterile, and some sterile water and a little container to put the water into. Normal saline may be used for irrigation. You may need a water-based lubricant if you're using the suction catheter through a airway of some kind. We're not going to worry about local anesthetics in this case, because we'll probably have an NPA in case. We'll also have a resuscitation bag and other emergency equipment like an EKG monitor, an oxygen saturation monitor, something along that line to monitor them. So here's a regulator that is there. You can see the one on the left is what we would find in the ICU. The one on the right is a portable unit, but they both have the ability to regulate the vacuum that is being applied. And then there's collection tubing and a collection canister, which is there. Here's my canisters and my connecting hose. Some catheters or some different types of suction catheters that exist. On the left-hand side, we have the Yankauer or rigid tonsil suction. In the middle, we have a standard flexible suction catheter that has a thumb port. You can see right here. And then there's also a closed suction system where we end up having for patients that have a need to be suctioned multiple times during a day. The catheter itself has multiple tips on it or multiple openings that basically are there to reduce trauma associated with the suctioning procedure. Lori will take, no, actually Lori will not. We will cover that in this portion of the course. There's multiple different types of specialty catheters. One I want you to do, that I do want you to know is the letter A there, what is known as the coude or bronchotrach. And this is designed for suctioning the left lung specifically. So the curved tip there, as you're inserting it, curved tip will direct it towards the left mainstem bronchus. Periodically, we need to sample some of the material that we are suctioning to identify, say, for instance, a culture and sensitivity, to find out what organism is growing and what antibiotics they are sensitive to. The device on the right-hand side there is called a Lucan sputum trap, and now that is what we will use for our performance evaluation on this. This is one called the DeLee trap. Basically, this is used in a delivery room. There's a little mouthpiece here. This is inserted into the baby's airway. And basically, the vacuum source is somebody sucking on this. It's pretty disgusting. I don't know to what extent they are currently still in use, but yeah, there you go. Some suction catheters have depth markings so that we know how far we're going down, because obviously if you go down too far, you can introduce some damage. Trauma is the most common complication to suctioning, along with hypoxemia. Let's talk about oral suctioning first. This is where we're going to use that Yankauer catheter, having again a vacuum source, collection container, and tubing, some sort of a regulator to regulate the amount of suction. You'll need to have some sort of normal saline or sterile water that is dated so that we know that it's not old, some kind of a copper basin to put it in, and obviously PPE for us. So what we're going to do is have that vacuum source attached to our collection bottle and then onto the catheter itself. This is what the tonsillar or Yankauer suction looks like. Sometimes they have a thumb control valve, sometimes they don't. But basically, it's a large opening at the distal end, so large volumes of fluid can be aspirated out. We obviously want to wash our hands, put on any PPE, gather the necessary equipment, make sure that it functions by putting the Yankauer tip, once it's attached to the suction tubing, into some water or sterile saline. We typically use -100 to -120 from a conventional system. That's the normal for adults. You can see there are different levels there for children and infant, and you should know those. -100 to -120 for an adult, -80 to -100 for a child, and -60 to -80 for an infant. We're going to go ahead and inform the patient of what we're doing and put them in the proper position. Obviously, we're suctioning out the mouth, so there's not a significant incidence of hypoxemia being created, but we certainly want to monitor the patient. We'll apply the vacuum and pass the catheter into the patient's mouth and across the back of the throat. Have the patient close their mouth around the catheter. If you've been to the dentist in the last 15 years, you know what this would feel like. And basically, then we would rinse and repeat as necessary. Once it's done, we want to put it back in a wrapper of some kind for future use. Turn off the suction. We would replace these catheters daily, and noting the date of change on the wrapper, and dispose them once it's done, especially if we have concerns about transmissibility of organisms. Remove our PPE, wash our hands, and obviously document. Respiratory therapists sucking the breath out of you since 1960. They've been longer than that, but you get the gist. Next type of suctioning we're talking about is nasotracheal suctioning. This is where we're actually going through the upper airway itself. We're using a different kind of catheter. In this case, it's going to be a disposable sterile kit that has everything you need in there. Usually, not usually, but it'll have a catheter itself that's somewhere on the order of 12 to 14 French, and the catheter sizes are measured in French as opposed to other units, and we'll explain that in a sec. Typically, it's about 20 to 22 inches long, has a beveled tip with a thumb port, and it is sterile as far as how it's packaged. Some other equipment you can see there for monitoring, and ideally, we want to pass this through the nasopharyngeal airway. So here's where our vacuum tubing would connect up to the catheter itself. The thumb control valve only allows for vacuum to be applied to the tip of the catheter when that thumb control valve is covered. This is a sterile kit. So we're going to, part of the big process with this, especially when we're doing open suctioning directly into an artificial airway, is we want to maintain sterility. So we'll go through when we do the PE as far as how to don the gloves and keeping everything in a sterile fashion. So when you take a look at the kit, you'll see some of those various things involved. Sometimes there's a sterile field that is applied that you can put stuff on. There usually is a basin or some sort of a container to hold sterile water. And again, just talking about suction catheters, there's a whole bunch of different styles out there. They're all generically having multiple tips, and that allows for, if this becomes occluded, say with it's actually touching the tissue, it's not applying a huge amount of suction, which would then cause some trauma to the tracheal wall. It has a secondary port, which allows for that vacuum to be dispersed. And we talked about the coude and the bronchotrach being ones that can go into the left main stem. Contraindications to suctioning: the absolute positive, never suction our patients with epiglottitis or croup. In the case of epiglottitis, you could put them into bronchospasm, which could potentially lead to death. Also, some other things, things like occluded nasal passages, problems with bleeding. Patient who's in laryngospasm, obviously we wouldn't. Patient who has irritable airways, some head, face, or neck trauma, or some upper infection. Some of the complications that can happen, we talked about trauma being the major one. That can be anywhere from just some irritation and bleeding through actual perforation. Hypoxia or hypoxemia is also a very common complication, and it's associated with the development of tachycardia and other dysrhythmias, and even potentially cardiac arrest. Sinus bradycardia may happen, especially in infants, because of stimulation of the vagus nerve. Hypotension, respiratory arrest, gagging and vomiting. In theory, because I'm sucking air out of the lungs, I could potentially create atelectasis. We talked about laryngospasm and bronchospasm. Talked about infection. Like I have atelectasis on there twice. Isn't that interesting? And because of the coughing that may happen, you may have an increase in intracranial pressure, which could be problematic. Again, we're going to wash our hands, put on our PPE, talk to the patient. Ideally, we want them in the high Fowler's position, and even in what we call the sniffing position. And if you think about how you sniff, your head comes forward a little bit, so there's a extension of the neck and a flexion of the head. Apply oxygen as necessary. Ideally, it'd be great to pre-oxygenate the patient with some oxygen prior to the procedure. If not on oxygen therapy, you can at least have them take some deeper breaths. Turn on the suction and set the proper pressure while the tubing is occluded. And we'll demonstrate that during the PE. We'll open our sterile water or sterile saline, keeping the cap in a clean position. Open any lubricant if necessary. Open the kit in a sterile fashion, putting on sterile gloves and the sterile drape. Open the basin. Place catheter in the dominant hand with non-dominant hand. Now, once we go ahead and we have two sterile gloves on. Once we make one sterile, the other one then becomes the non-dominant hand, typically becomes one that we're going to use to touch non-sterile things. So at that point, you'll tell us which is going to be your dominant and which is going to be your non-dominant. And then obviously you never want to have a situation where the hand that is sterile is touching something that is not sterile, like the water bottle. We'll test catheter function. Once it's been attached, we'll monitor the patient for various cardiopulmonary distress. We'll hold the catheter near the tip, have the patient stick out their tongue or take a slow, deep breath. We do not apply suction when the catheter is being inserted into the nasopharynx, ideally, again, through the nasopharyngeal airway. And once the patient begins to gag or cough, we want to remove it and attempt it again. What we're looking to attempt to do here is, because of that sniffing position, I have a better chance of that catheter actually going into the trachea. Once it passes through those vocal cords, the patient's going to be able to cough, and I can apply vacuum at that point in time. This is showing another picture as far as why proper positioning of the head is key. And they're not, in the sniffing position, the catheter is advanced. And then as inspiration, you can actually move the catheter forward. If an obstruction is met, don't force the catheter. You can try rotating it or trying the other nostril. If they're tolerating it, we can continue to have them take slow, deep breaths and sticking out their tongue, and advance the catheter until resistance is met or coughing begins. At that point, we'll withdraw the catheter slightly and apply intermittent suction by placing thumb over the suction port, and then removal of the catheter. Now, this whole procedure should not take more than 10 to 15 seconds, especially when vacuum is being applied. When it's complete, remove the catheter, rinse it, and then suction the mouth and nose after you're done. And then there's some post-oxygenation that you have to address once the procedure is done. And again, if you're doing this nasotracheal suctioning going through the nasal passage, really there should be a nasopharyngeal airway in place so that there's not trauma that is there. We're going to dispose of equipment properly, turn off the vacuum, reassess the patient and reposition them, remove any PPE, and wash our hands, and we'll do a demo on that. And I believe this is where we're going to end up stopping for today, and we'll pick this up tomorrow then.